Welcome to Pediatric Case Review. Today we'll explore autoimmune hepatitis in children, a chronic inflammatory liver condition caused by immune-mediated injury to hepatocytes. This comprehensive lecture aims to equip general pediatricians with the knowledge to recognize, diagnose, and manage this condition. We'll cover pathophysiology, clinical presentation, diagnostic approach, treatment guidelines, and long-term outcomes through case-based scenarios. Let's enhance our understanding of this important pediatric liver disorder. Let's begin with a case. A 13-year-old girl presents with elevated transaminases. Her liver biopsy shows interface hepatitis with plasma cell infiltration. Which immunologic mechanism best explains the pathogenesis of autoimmune hepatitis? A. Loss of T-cell tolerance to hepatic antigens. B. Direct viral infection of hepatocytes. C. Drug-induced hepatotoxicity. D. Primary biliary damage. The correct answer is A. Loss of T-cell tolerance to hepatic antigens. Autoimmune hepatitis results from a breakdown in immune tolerance to liver antigens. CD4 positive T cells recognize self-antigens and initiate an immune response against hepatocytes. This is facilitated by defective regulatory T cells that would normally suppress such responses. Genetic factors, particularly HLA-DR3 and DR4 haplotypes, confer susceptibility. Environmental triggers like medications or infections may initiate the autoimmune cascade in genetically predisposed individuals. This diagram illustrates the pathophysiology of autoimmune hepatitis. In normal conditions, regulatory T cells maintain tolerance to liver antigens. In autoimmune hepatitis, this tolerance breaks down. Environmental triggers activate antigen-presenting cells that stimulate autoreactive CD4 T cells. These T cells infiltrate the liver and release pro-inflammatory cytokines, recruiting other immune cells. B cells produce characteristic autoantibodies. The resulting chronic inflammation leads to progressive hepatocyte damage, fibrosis, and potentially cirrhosis if untreated. Consider this case. An 11-year-old boy presents with fatigue, jaundice, and abdominal pain for 3 weeks. His sister has type 1 diabetes. Which clinical presentation pattern is most common in pediatric autoimmune hepatitis? A. Acute hepatitis resembling viral infection. B. Fulminant hepatic failure. C. Insidious onset with nonspecific symptoms. D. Incidental finding of elevated transaminases. The correct answer is C. Insidious onset with nonspecific symptoms. Most children with autoimmune hepatitis present with vague, nonspecific symptoms that develop gradually over weeks to months. These include fatigue, malaise, anorexia, weight loss, and intermittent abdominal pain. This insidious presentation often leads to diagnostic delays. Acute presentations resembling viral hepatitis occur in about 25% of cases. Fulminant hepatic failure is rare, seen in less than 5% of children. Incidental discovery through elevated liver enzymes occurs in 10 to 15% of cases. This table illustrates the spectrum of clinical manifestations in pediatric autoimmune hepatitis. Constitutional symptoms include fatigue, malaise, and fever. Gastrointestinal symptoms include jaundice, right upper quadrant pain, vomiting, and clay-colored stools. Extrahepatic manifestations are common and include arthritis, nephritis, and skin manifestations. Complications like portal hypertension may be present at diagnosis in up to 30% of children. Note that autoimmune hepatitis frequently coexists with other autoimmune conditions, highlighting the importance of thorough systemic review in affected patients. Here's our next case. A 14-year-old girl presents with fatigue and jaundice. Initial labs show AST 450 units per liter, ALT 520 units per liter. Which laboratory finding is most characteristic of autoimmune hepatitis? A. Elevated alpha-fetoprotein. B. Hypergammaglobulinemia. C. Low alkaline phosphatase. D. Elevated direct bilirubin only. The correct answer is B. Hypergammaglobulinemia. Elevated immunoglobulin G levels, particularly polyclonal gammopathy, is a hallmark finding in autoimmune hepatitis, present in over 80% of pediatric cases. Transaminases are typically elevated 5 to 20 times normal, reflecting hepatocellular injury. Alkaline phosphatase may be normal or moderately elevated. Bilirubin elevation varies based on disease severity. Alpha-fetoprotein might be mildly elevated but isn't characteristic. Serum IgG level serves as both a diagnostic marker and a monitoring tool during treatment. This flowchart outlines the systematic laboratory approach to suspected autoimmune hepatitis. Initial evaluation includes liver function tests, complete blood count, and coagulation studies. Second-tier testing includes immunoglobulin levels with particular attention to IgG, which is typically elevated. Autoantibody testing includes anti-nuclear antibody, smooth muscle antibody, liver-kidney microsomal antibody, and soluble liver antigen. Concurrent testing should exclude other causes of liver disease including viral hepatitis, Wilson disease, and alpha-1 antitrypsin deficiency. This systematic approach facilitates timely diagnosis. Let's consider this case. A 9-year-old boy with elevated transaminases has positive anti-LKM1 antibodies. Which type of autoimmune hepatitis is this patient most likely to have? A. Type 1 AIH. B. Type 2 AIH. C. Type 3 AIH. D. Overlap syndrome with PSC. The correct answer is B. Type 2 AIH. Autoimmune hepatitis is classified into different types based on autoantibody profiles. Type 2 AIH is characterized by the presence of anti-liver kidney microsomal type 1 antibodies. This subtype typically affects younger children, with a peak age of 2 to 14 years. Type 1 AIH is characterized by anti-nuclear and/or anti-smooth muscle antibodies and affects all age groups. Type 3 AIH, defined by antibodies against soluble liver antigen, is less commonly recognized. Overlap syndromes with primary sclerosing cholangitis show different antibody patterns. This table compares the characteristics of different autoimmune hepatitis subtypes. Type 1, positive for ANA and/or SMA, accounts for 2/3 of pediatric cases and generally responds well to standard therapy. Type 2, positive for anti-LKM1, typically affects younger children, presents more acutely, and may require more aggressive immunosuppression. Type 3, characterized by anti-SLA, remains controversial as a distinct entity. Each type shows differences in presentation severity, treatment response, and relapse rates. Understanding these distinctions helps guide therapeutic decision-making and predict disease course. Consider this diagnostic challenge. A 12-year-old girl has elevated transaminases, hypergammaglobulinemia, positive ANA at 1 to 320 dilution, and interface hepatitis on biopsy. Which feature would argue against a diagnosis of autoimmune hepatitis? A. Absence of jaundice. B. History of recent EBV infection. C. Family history of autoimmunity. D. Elevated alkaline phosphatase at 2 times upper limit of normal. The correct answer is B. History of recent EBV infection. Recent Epstein-Barr virus infection can cause a clinical, biochemical, and histological picture that mimics autoimmune hepatitis, including transient autoantibody positivity. Absence of jaundice is common in autoimmune hepatitis, as many patients present with chronic disease without overt jaundice. Family history of autoimmunity actually supports the diagnosis, as genetic predisposition is common. Mildly elevated alkaline phosphatase doesn't exclude autoimmune hepatitis, though marked elevations might suggest an overlap with biliary disease. This table presents the simplified diagnostic criteria for autoimmune hepatitis, which includes 4 key elements: autoantibody titers, IgG levels, liver histology findings, and exclusion of viral hepatitis. A score of 6 or more indicates definite autoimmune hepatitis, while 5 points suggest probable disease. While these criteria were developed for adults, they perform well in pediatric populations with some modifications. In children, lower autoantibody titers may be significant, and histologic patterns may differ slightly. Clinical judgment remains essential, particularly in atypical cases. Let's discuss histopathology. A liver biopsy is performed on a 10-year-old with suspected AIH. Which histopathological finding is most characteristic of autoimmune hepatitis? A. Steatosis with ballooning degeneration. B. Interface hepatitis with plasma cell infiltration. C. Periportal copper deposition. D. Bile duct proliferation and fibrosis. The correct answer is B. Interface hepatitis with plasma cell infiltration. The histological hallmark of autoimmune hepatitis is interface hepatitis, characterized by inflammatory cell infiltration crossing the limiting plate into the liver parenchyma. Plasma cells are typically abundant in the portal and periportal regions. Other features include emperipolysis and hepatocyte rosette formation. Steatosis with ballooning is more typical of non-alcoholic steatohepatitis. Periportal copper deposition suggests Wilson disease. Bile duct proliferation and fibrosis are characteristic of primary sclerosing cholangitis or biliary atresia. These histopathology images demonstrate the classic features of autoimmune hepatitis. The top left shows interface hepatitis with lymphoplasmacytic infiltrate extending from the portal tract into the surrounding parenchyma. The top right demonstrates prominent plasma cells, which are highly characteristic. Bottom left shows hepatocyte rosette formation. Bottom right illustrates emperipolysis, where lymphocytes invade hepatocytes. These features, while not pathognomonic, strongly support the diagnosis of autoimmune hepatitis when considered alongside clinical and serological findings. Biopsy also provides important information about fibrosis stage. Here's our next diagnostic challenge. A 15-year-old with elevated transaminases, hypergammaglobulinemia, and positive ANA also has persistently elevated GGT and alkaline phosphatase. Which diagnosis should be most strongly considered? A. Drug-induced liver injury. B. Wilson disease. C. Autoimmune sclerosing cholangitis. D. Alpha-1 antitrypsin deficiency. The correct answer is C. Autoimmune sclerosing cholangitis. The combination of features suggesting autoimmune hepatitis with persistently elevated cholestatic markers, GGT and alkaline phosphatase, should raise suspicion for autoimmune sclerosing cholangitis, an overlap syndrome. This condition is particularly common in children, representing up to 50% of cases initially diagnosed as autoimmune hepatitis. Drug-induced liver injury can mimic AIH but typically lacks hypergammaglobulinemia. Wilson disease presents with low alkaline phosphatase and other characteristic features. Alpha-1 antitrypsin deficiency has distinctive histological features and diagnostic testing. This table compares autoimmune hepatitis with key differential diagnoses. While Wilson disease can present with autoimmunity, it typically shows low alkaline phosphatase, Kayser-Fleischer rings, and low ceruloplasmin. Drug-induced liver injury may produce autoantibodies, but typically resolves with drug withdrawal. Viral hepatitis can be distinguished by serological markers. Primary sclerosing cholangitis and autoimmune sclerosing cholangitis require cholangiography for diagnosis. Alpha-1 antitrypsin deficiency shows characteristic PAS-positive, diastase-resistant globules on histology. A systematic approach to these differentials is essential for accurate diagnosis. Let's discuss treatment. A 14-year-old girl is diagnosed with type 1 AIH based on clinical, laboratory, and histological findings. Which is the most appropriate initial treatment regimen? A. Prednisone monotherapy. B. Prednisone plus azathioprine. C. Budesonide plus azathioprine. D. Tacrolimus monotherapy. The correct answer is B. Prednisone plus azathioprine. Standard induction therapy for autoimmune hepatitis combines prednisone with azathioprine. This approach allows for lower steroid doses, reducing side effects while maintaining efficacy. Typical starting doses are 1 to 2 mg per kilogram per day of prednisone, maximum 60 mg, and 1 to 2 mg per kilogram per day of azathioprine. Prednisone monotherapy is an option when azathioprine is contraindicated. Budesonide may be considered in mild disease without cirrhosis. Tacrolimus is typically reserved for refractory cases. This table outlines the standard treatment regimen for pediatric autoimmune hepatitis. Initial therapy typically continues until biochemical remission, usually within 6 to 12 months. Prednisone is then gradually tapered while maintaining azathioprine. Monitoring should include liver biochemistry every 2 to 4 weeks initially, then less frequently during maintenance therapy. Complete blood counts are essential to monitor for azathioprine-induced myelosuppression. Growth, bone density, and metabolic parameters should be regularly assessed due to steroid side effects. Treatment typically continues for at least 2 to 3 years after biochemical normalization. Consider this treatment scenario. A child with AIH has been on prednisone and azathioprine for 6 months. Transaminases have normalized but IgG remains slightly elevated. Which is the most appropriate next step? A. Continue current therapy without changes. B. Increase azathioprine dose. C. Perform repeat liver biopsy. D. Switch to alternative therapy, cyclosporin. The correct answer is A. Continue current therapy without changes. Normalization of transaminases indicates biochemical remission, which is the primary goal of initial therapy. While IgG normalization often parallels transaminase improvement, it may lag behind and remain mildly elevated despite adequate disease control. Current guidelines do not recommend increasing immunosuppression based on isolated IgG elevation when transaminases are normal. Repeat liver biopsy is not routinely indicated at this stage but may be considered before stopping therapy. Alternative agents like cyclosporine are reserved for treatment failure. This flowchart illustrates the assessment and management of treatment response in pediatric autoimmune hepatitis. Complete biochemical response is defined as normalization of transaminases and IgG, which occurs in 70 to 80% of patients within 6 to 12 months. Incomplete response warrants dose optimization or consideration of alternative agents. Non-response or disease progression should prompt re-evaluation of the diagnosis, assessment of medication adherence, and consideration of second-line therapies. Once complete biochemical response is achieved and maintained, gradual steroid tapering can begin while monitoring for relapse. Let's address a common treatment challenge. A 12-year-old with AIH develops significant Cushingoid features despite biochemical improvement on prednisone and azathioprine. Which is the most appropriate management strategy? A. Switch from prednisone to budesonide. B. Accelerate prednisone taper and increase azathioprine. C. Add mycophenolate mofetil and taper prednisone. D. Switch to tacrolimus and taper prednisone. The correct answer is A. Switch from prednisone to budesonide. Budesonide has high first-pass hepatic metabolism, resulting in fewer systemic side effects than prednisone. For patients with significant steroid toxicity but good disease control, switching to budesonide is appropriate if the patient doesn't have cirrhosis. Budesonide is contraindicated in cirrhosis due to portosystemic shunting. Accelerating prednisone taper without alternative strategy risks disease flare. Mycophenolate mofetil is typically used when azathioprine is not tolerated. Tacrolimus is usually reserved for refractory disease rather than managing steroid side effects. This table outlines alternative therapies for pediatric autoimmune hepatitis. Mycophenolate mofetil is useful when azathioprine is not tolerated, typically due to side effects or thiopurine methyltransferase deficiency. Calcineurin inhibitors like tacrolimus and cyclosporin are effective for treatment refractory disease. Rituximab has shown promise in difficult cases by targeting B cells. Budesonide offers a steroid-sparing option for non-cirrhotic patients. Each alternative therapy requires specific monitoring and has unique side effect profiles. Treatment decisions should consider the risk-benefit profile for each individual patient. Let's consider long-term management. A 13-year-old has been in biochemical remission for 2 years on low-dose prednisone and azathioprine. Which factor would most support attempting medication withdrawal? A. Normalization of IgG and transaminases. B. Resolution of symptoms. C. Histological remission on repeat biopsy. D. Patient request to stop medications. The correct answer is C. Histological remission on repeat biopsy. While biochemical remission is essential before considering treatment withdrawal, histological remission provides the strongest evidence that inflammation has resolved. Studies show that persistent histological inflammation despite normal biochemistry predicts relapse after treatment withdrawal. Before attempting medication withdrawal, patients should have at least 2 years of biochemical remission and ideally histological remission. Even with these criteria, relapse rates range from 20 to 80% after medication discontinuation. Close monitoring is essential, with frequent liver tests for at least 1 year after withdrawal. This timeline illustrates the long-term monitoring approach for pediatric autoimmune hepatitis. During active treatment, monitoring occurs every 3 to 6 months once stable. When considering treatment withdrawal, a liver biopsy may be performed to assess histological remission. After withdrawal, intensive monitoring is needed every 1 to 3 months initially, then every 3 to 6 months for at least 2 years. Even after successful withdrawal, lifelong surveillance is recommended every 6 to 12 months, as late relapse can occur. Regular assessment for complications and comorbidities, including other autoimmune conditions, is essential. Let's examine complications. A 16-year-old with AIH, diagnosed at age 8, presents with hematemesis and is found to have esophageal varices. Which factor most likely contributed to this complication? A. Medication non-adherence. B. Development of hepatocellular carcinoma. C. Progression to cirrhosis despite treatment. D. Overlap with primary sclerosing cholangitis. The correct answer is C. Progression to cirrhosis despite treatment. Despite adequate treatment, about 20% of children with autoimmune hepatitis progress to cirrhosis. Esophageal varices result from portal hypertension secondary to cirrhosis. Risk factors for progression include delay in diagnosis, incomplete response to treatment, and frequent relapses. While medication non-adherence can certainly contribute, progression can occur despite adherence. Hepatocellular carcinoma is rare in pediatric AIH. Overlap with primary sclerosing cholangitis would typically show other biliary features before varices develop. This chart summarizes long-term outcomes in pediatric autoimmune hepatitis. With appropriate treatment, 10-year survival rates exceed 90%, and transplant-free survival is approximately 80%. Poor prognostic factors include presentation with cirrhosis, incomplete response to initial treatment, multiple relapses, and type 2 disease. Complications include cirrhosis in 20 to 30% of cases, portal hypertension in 15 to 20%, and hepatocellular carcinoma in less than 1%. The risk of hepatocellular carcinoma increases with duration of cirrhosis, highlighting the importance of surveillance. Let's consider a challenging scenario. A 4-year-old presents with acute liver failure. Lab work shows markedly elevated transaminases, INR 2.5, and positive anti-LKM1. Which treatment approach is most appropriate? A. Standard dose prednisone and azathioprine. B. High dose intravenous methylprednisolone. C. Liver transplantation evaluation without immunosuppression trial. D. Plasmapheresis with low dose immunosuppression. The correct answer is B. High dose intravenous methylprednisolone. Acute liver failure with autoimmune features requires aggressive immunosuppression, typically with intravenous methylprednisolone at 2 to 3 mg per kilogram per day. Early intensive treatment can lead to recovery and avoid transplantation in up to 50% of cases. Concurrent transplantation evaluation is essential as deterioration can be rapid. Standard oral therapy may be insufficient for acute severe disease. Proceeding directly to transplantation without an immunosuppression trial misses a potential recovery opportunity. Plasmapheresis may be considered as adjunctive therapy but not as primary treatment. This table outlines management approaches for special scenarios in pediatric autoimmune hepatitis. Acute severe disease requires intensive immunosuppression and close monitoring in an experienced center. Very young children with AIH, particularly type 2, may need more aggressive therapy and careful monitoring. Adolescent pregnancy requires medication adjustments, as azathioprine is generally continued while prednisone is minimized. Post-transplant AIH recurrence occurs in 10 to 40% of cases and requires increased immunosuppression. Concurrent autoimmune diseases like inflammatory bowel disease may necessitate coordinated treatment approaches. Let's explore recent advances. A 15-year-old with difficult-to-treat AIH has failed standard therapy and calcineurin inhibitors. Which therapeutic approach shows the most promise for refractory pediatric AIH? A. Anti-TNF therapy, infliximab. B. B-cell depletion, rituximab. C. Fecal microbiota transplantation. D. Gene therapy targeting immune regulation. The correct answer is B. B-cell depletion with rituximab. Among emerging therapies for refractory autoimmune hepatitis, rituximab has the most clinical evidence in pediatric cases. By depleting B cells, rituximab reduces autoantibody production and may interrupt the autoimmune process. Case series reports successful outcomes in difficult-to-treat pediatric AIH. Anti-TNF therapy has shown mixed results and may paradoxically induce autoimmune hepatitis in some patients. Fecal microbiota transplantation remains experimental despite the growing interest in gut-liver axis. Gene therapy approaches are still in preclinical development. This figure illustrates the pipeline of emerging therapies for pediatric autoimmune hepatitis. Current clinical approaches include B-cell targeted therapies like rituximab and anti-CD20. Regulatory T-cell modulation approaches are in early clinical trials. The JAK-STAT pathway inhibitors show promise in preclinical models. Gut microbiome modulation strategies are being explored based on growing evidence of gut-liver axis involvement. Biomarker development focuses on non-invasive methods to assess disease activity and predict treatment response. These advances aim to provide more targeted, effective, and less toxic therapeutic options. To summarize our comprehensive review of autoimmune hepatitis in children, remember these key points. Early recognition and prompt treatment significantly improve outcomes. The standard regimen of prednisone and azathioprine remains effective for most patients. Histological assessment provides crucial diagnostic and prognostic information. Long-term monitoring is essential even after biochemical remission. A multidisciplinary approach involving hepatology, rheumatology, and nutrition optimizes care. The therapeutic landscape continues to evolve with promising targeted therapies. Thank you for following this lecture on Pediatric Case Review. Thank you for joining us for this comprehensive lecture on autoimmune hepatitis in children. If you found this information valuable, please subscribe to the Pediatric Case Review YouTube channel and enable notifications to stay updated on our latest educational content. We welcome your questions and comments below this video as they help us create more targeted educational materials. Coming soon, we'll be exploring other important pediatric conditions including inflammatory bowel disease, juvenile idiopathic arthritis, and pediatric cardiac emergencies. Until next time, this is Pediatric Case Review, dedicated to advancing pediatric knowledge.